This lecture is discussing the leadership and management in nursing. By its very nature, the nursing role is one of leadership. Across the healthcare continuum, regardless of our role or practice setting, we are looked to as leaders. Some nurses spend years leading in an informal leadership capacity, while others take a more formal management and leadership role. The call to leadership moves all of us to a higher plane of responsibility and accountability with or without a management title. It is inherent in all nursing positions from staff nurse to CEO. We all have similar goals and responsibilities for patient care mainly. With all the changes currently underway in our healthcare delivery system and the nursing profession, all nurses must thrive to emulate the hallmarks of good management and leadership and never stop working on our professional growth. We all need to stay informed and be politically savvy. We need to know what our professional journals and nursing organizations are saying and advance our education. In the end, all nurses must be visionaries and critical thinkers, skilled communicators and teachers. And the good news is you do not need a formal manager or leader title required to do any of these things. Please take a moment to stop the presentation in order to review the objectives for those 3 chapters that will be presented in this lecture. Some redundant objectives were eliminated. We'll start as usual by defining the concept. So, a leader is a person that others follow voluntarily and willingly. In 1959, Bennis defined leadership as the process by which an individual influences followers to behave in a desired manner. Kuzes and Posner defined leadership as, and I quote, the art of mobilizing others to want to struggle for shared aspirations, end quote. Additionally, Lidlow and Couples defined leadership as, quote, the ability to assess, develop, maintain, and change the organizational culture and strategic system to optimally meet the needs and expectations of the external environment. So, leadership is mainly about developing a vision and allowing individuals to work toward change. It involves creating a shared mission, tackle political, organizational, and resource barriers, and inspiring and motivating others. Leadership have investigated by many scholars, as it is evidenced by the plethora of definitions that exist. It is apparent that there is no single accurate definition of leadership. So for the purpose of this lecture, we will use leadership is an interactive process that provides needed guidance and direction. So leadership involves 3 dynamic elements: a leader, a follower, and a situation. The leader provides guidance to followers, directing them toward a vision or goal and giving support to enable their success in that particular situation or setting. In nursing's long history, there have been many leaders and managers. Dahlkemper mentions 4. Florence Nightingale, who started the modern-day nursing, Lillian Ward and Mary Brewster, who started public health nursing, and Jean Watson, an American nurse theorist and nursing professor who is best known for her theory of human caring. This theory allowed the nursing profession to develop its own paradigm rather than following the medical paradigm. Others that you might have heard of are Dorothea Dix, the mental health nursing pioneer, Clara Barton, Civil War nurse and founder of the American Red Cross, Margaret Sanger started Planned Parenthood and helped in the development of the birth control pill, Mary Breckenridge, nurse midwife, and Madeline Leininger, transcultural nursing. So, leadership involves qualities related to a person's character and behaviors, as well as roles within a group or organization. It requires that the person have the ability to guide and influence other person, group, or both to think in a certain way, to achieve common goals, or to provide inspiration for change. To be effective, leaders and managers must possess certain qualities, says Marquez and Houston in their paper from 2015. An ability to gain respect of others through competence and shared goals. An expertise in communication skills, both oral and written. A capacity to motivate others to achieve a particular purpose or to accomplish goals. Well, any healthcare provider has the potential to be a leader in terms of influencing a group or exercising power in a particular situation. Accordingly, LVNs also may be leaders, informally or formally. For example, an LPN working on a medical surgical unit may assume responsibility for organizing social events for fellow employees. A more formal leadership role would be acting as chairperson of the unit staffing policy committee or working as a DSD. Management entails assigned functions such as planning, organizing, directing, and controlling to meet specific objectives within an organization. The manager's overall goal is to coordinate and direct resources, which include workspace, supplies, equipment, budgetary concerns, and services. In addition, managers direct and coordinate the work of assigned employees. So managers first are assigned a position in an organization, and second, have a legitimate and more formal source of power owing to the delegated authority that accompanies their position. From a third point of view, they are expected to carry out specific functions, duties, and responsibilities. They will need to emphasize control, decision-making, decision analysis, and results. Managers manipulate resources to meet organizational goals and will direct willing and unwilling subordinates. While a key feature is the individual manager's responsibility and accountability for the accomplishment of tasks. Integrated leaders or managers have traits that distinguish them from just leaders or managers, and those will be thinking in the long term, seeing the big picture, influencing others outside their own group, emphasizing vision, values, and motives, being politically astute and embracing change and modification. In addition, integrated leaders or managers will set reasonable goals, will think positively, and they are willing to take risks. Leadership and management have very unique and powerful differences and yet are often used interchangeably. One nurse can be both a leader and a manager, however. In the leader role, he or she might be establishing vision and goals for her unit, and as a manager, she plans and organizes the tasks that need to be done to accomplish the vision. The goals of managers is to get the work done through others. Management represents the ability to organize details so that the leader's vision and goal can be achieved successfully. If the leadership is ineffective, however, it does not matter how great the managers are. Or as Stephen Covey puts it, efficient management without effective leadership is like straightening deck chairs on the Titanic. The manager is seen as the person who is responsible for getting work done through others. And this will require excellent interpersonal relationship skills, a broad understanding of the organization and how it works, and the ability to perceive the organization as client-focused, to establish goals and objectives, to use person power and physical resources. Not the last, to act as an agent of change. Leaders and managers can have these traits naturally, or they can be learned and developed. In other words, everyone can become a better leader or manager by studying and practicing those skills. The formal leader is a member of an organization who has given authority by virtue of his position to lead the organization to achieve organizational goals. An informal leader has no formal organizational authority to influence others, but this person possesses special skills and talents that allow him or her to influence and lead other members of the organization. While the formal leader is officially bound to drive members toward organizational goals and is responsible for results or outcomes of the efforts at the end, the informal leader do not have such official commitment towards organizational goals and may not be directly responsible for final results. In other words, may not be accountable for it. The goals of nursing leadership are quality patient care, high patient satisfaction, increased patient safety with few adverse events and complications, and creation of a supportive practice environment for nurses. Informal leaders in nursing are often nurses with a high level of clinical competency, first and foremost, and those people are recognized as experts. This type of leader influences the group, comes from the team, and is actually chosen by the team. Informal leaders don't have the power to hire or fire other staff or influence compensation, but are often very charismatic with an outspoken nature or a very strong will. Many informal leaders in nursing can be troubleshooters, super users, and champions who volunteer for extra jobs, serve on unit or hospital-wide committees, and shared governance councils. The informal leader is often taped to provide feedback for new projects and may assume supportive roles such as preceptor, educator, and charge nurse. Leadership theory has evolved in waves since the beginning of the 20th century. Each wave will include specific theories founded on common assumptions and incorporates different dimensions. As new waves of theory have emerged, but they have not completely replaced previous waves, but instead added to the understanding of this very complex concept. As theory and research have advanced over time, the concept of leadership has changed as well. Leadership in nursing is no longer seen as a set of traits. It is now understood as a multifaceted and dynamic process. Today's leaders must know themselves, understand and relate effectively with their followers, and be responsive to a variety of situational dynamics and needs. The oldest leadership theories illustrate the great man so-called approach and are based on the assumption that leaders are born, not made. In these theories, the hypothesis was that when a situation demands leadership, a leader emerges to assume control. Prior education or special preparation for leadership does not occur. Another key assumption of those theories is that traits can be used as criteria to select effective leaders. Research based on the great man approach focuses on identifying traits of great leaders. Historically, this included physical characteristics, let's say height, and demographic traits, for example, male from an aristocratic background. Now, this research addresses personality, and as an example for that, we are looking for self-confidence and decisiveness, intellect as a high IQ and an ability to reflection, social attributes, friendliness, and sense of humor. When people around the world were polled and what qualities and what they looked for in a leader, they responded with very similar answers that can be summarized into 4 traits. They are looking for honesty, forward-looking, inspiring, and competent person. The second wave of leadership theory concentrates on leader behaviors. The core assumption of this wave is that effective leaders use different behaviors than ineffective leaders. Research using behavioral leadership theories has shown that effective leaders demonstrate high concern for employee needs, feelings, and morale, let's say consideration for the others, and also address task accomplishment and organizational productivity as, let's say, initiating structure. A contemporary behavioral leadership theory popular in nursing is the emotional intelligence. Emotional intelligence, or the EI, how you may see it abbreviated, is composed of 5 components: self-awareness, self-regulation, motivation, empathy, and social skills. The theory hypothesis is based on the improvement of their effectiveness. Leaders must develop their capabilities in all those 5 components. Emotional intelligence has been used by nurse researchers to study the impact of nursing leadership styles on patient outcomes and nurses' responses to hospital restructuring. Emotional intelligence highlights the importance of knowing one's self, importance of reflection, openness to feedback, and continuous learning in the leadership role. There is a third wave of leadership theory, and this is the situational and contingency theory, that the main focus is to explain why some leadership approaches are effective in one situation but will not going to work in another one. This wave theory takes into consideration the subtle and complex way in which a leader's traits and behaviors, followers' needs and values, and situational parameters will interact. It challenges the assumption that there is a one best way to lead. Education and training to enhance leader effectiveness gained importance during this wave. Well, we discussed 3 waves. Let's look into the 4th wave of leadership theory. And this new wave is referred to as charismatic and transformational leadership. The underlying assumption is that leaders inspire. They will intellectually stimulate and recognize the contributions of their followers. Charismatic leaders influence followers through their personality and charm. They develop an emotional relationship that inspires and motivates followers. Transformational leaders possess similar characteristics, and in addition, they will convey high expectations to their followers, challenging their assumptions about what can be attained and building their commitment to an organizational vision. Transformational leaders rouse followers to achieve something of significance. They positively affect individual initiative and accomplishment, and they will encourage trust and performance within work groups. Many have advocated for the use of transformational leadership in nursing, and studies of charismatic and transformational nursing leadership have shown that they are associated with high nurse satisfaction, very low nurse turnover, empowerment, and high productivity and effectiveness. You see now, the complexity of the leadership approach derives from the complexity of science, and a relatively new theory that reflects the dynamism and knowledge-based nature of the world in 21st century emerged. Using the complexity science as a framework produces a markedly different approach to leadership than the theories presented previous. Complexity science now will assume the interconnectedness among the parts of a system and between the system and its external environment. Sounds complicated, right? Well, the interaction among those interconnected parts can affect the entire system, often in substantial ways. Another assumption of complexity science is the non-linearity. Throughout the decades, organizational theory has been based on the assumption of some type of predictability. The organizations are designed to work like a well-oiled machine. Now we have this new theory, the complexity science, however, recognizing that organizational processes are often nonlinear and very unpredictable. Through the dynamic interplay of negative and positive feedback, an organization is able to make changes to keep abreast of the environmental context. Self-organization is another assumption of complexity science. Employees at the front lines will self-organize to enable the organization to adapt, to change, to innovate, and to create new capabilities. Leaders who apply complexity science will not direct or control the process of solving organizational problems. Instead, they invite workers to connect with each other to create a solution. The complexity leader will provide resources to them, such as Data and information about the problem help them recognize their ability to find a solution, including innovations that already may have been implemented at the front lines. Set parameters for action and boundaries for the solutions, and remove organizational barriers so that the solution can emerge from the workers most affected by the problem. Complexity science is beginning to appear in the nursing literature. In one report, the use of complexity science approaches helped newly licensed registered nurses manage patient care dilemmas that threaten the quality of patient care. An investigation of care for nursing home residents showed that interaction strategies aligned with complexity science increase the staff's ability to deliver better care. You need to understand that you are not a leader if no one is following you. Most employees spend the greatest part of their work life as followers. Leaders are followers in some settings, activities, and situations. Effectiveness of a leader depends on the relationship between him or her as a leader and the followers. Good followers have confidence, honesty, they are credible and committed to the organization and are able to manage themselves well. How followers interact with leaders can be viewed as a continuum, with responses ranging from resistance to passivity and active participation in organizational activities. Consequently, success of an organization is closely tied to the interaction between leaders and followers. A vision is a leader's ideological statement of a desired long-term future for an organization. It is the future that the leader wants to create, thus it is something to be worked toward over a period of time. To move your followers toward a vision, you as a leader will need to use several processes. The three most commonly used processes are communication, decision-making, and change. Social power is the potential influence of one individual over another. Leaders derive their social power from a variety of sources. A leader's style influences how he or she will use power. For example, formal leaders' power, or what is called legitimate power, is derived in part from the position they hold. Transactional leaders use what is called the reward power, while an authentic leader uses pure information power. Other sources of power come from who you know, which is known as connection power, and what you know, what is called the expert power. There is even power to punish or threaten, but this is not the best way to get people to follow your leadership. We can find that there are many identified styles of leadership, and servant leadership is one that has grown in popularity in the last few years. Back in the 1970s, Robert Greenleaf created this term to describe leaders who influence and motivate others by building relationships and developing the skills of individual team members. A servant leader makes sure the needs of the individual team members are addressed. In this style of management, the entire team has input into decision-making based on the organization's values and ideals. Servant leaders create devoted followers in response to positive attention they are given. Characteristic skills of a servant leader will include listening and acceptance, awareness, persuasion, foresight, commitment to the growth of others, and building community within the organization. What will be a different style? Well, a very similar style, transformational leadership, is also based on building relationships and motivating staff members through a shared vision and mission. Transformational leadership typically have charisma to communicate vision, confidence to act in a way that inspires others, staff respect and loyalty from letting the team know they are important, and are masters at helping people do things they weren't sure they could do by giving encouragement and praise. A similar style to that is the democratic leader who will encourage open communication and staff participation in decisions. Workers are given responsibility, accountability, and feedback regarding their performance. Relationships are important as well to this type of leadership who places a focus on quality improvement of the system and processes rather than on mistakes of individual team members. An authoritarian or autocratic leadership style is demonstrated when a leader will make all the decisions without considering any input from the staff. Negative reinforcement, and punishment are often used to enforce rules. Because knowledge is seen as power, critical information may be withheld from the team. Mistakes are not tolerated and blame is placed on individuals rather than on faulty processes. Now, the positive side of this style, because it has to be one, is that it works perfectly in emergencies or chaotic situations where there is little time to discussion. It is very useful when enforcing policies and procedures that protect resident health and safety, but it does not promote trust, communication, or teamwork when used for day-to-day operations. Usually, the authoritarian leaders are often seen as micromanagers. As opposed to that, laissez-faire leaders, laissez-faire comes from French, which means let the people be, is a style in which the leader provides little or no direction or supervision and prefers to take a hands-off approach. Decisions are not made, changes rarely occur, and quality improvement is typically reactive, not proactive. It is most often used by new and inexperienced leaders or by those at the end of their career who choose not to address issues since things will soon be changed by their replacement leader. We are continuing with the leadership styles. The autocratic nurse is what is called the boss, full stop. A nurse who leads using this management style makes all the decisions and gives very specific orders and directions to subordinates and tends to discourage questions or dissent. There's also a low tolerance for mistakes and the people who make them. Now, let's see when is this style efficient, when it will work best. For example, for simple or very straightforward tasks, or making sure that strict legal or medical guidelines are adhered to. It can also help in emergency situations when there needs to be a strong voice giving direction. When this style doesn't work so well is when a nurse manager wants to build trust and teamwork among other team members or encourage creative problem solving. The democratic nurse manager will take input from subordinates and encourages open communication. The decision-making ultimately stays with the manager, but stakeholders and team members are asked for honest feedback and given feedback in return. Let's see when this style works the best. It will work when the nurse wants to build relationships with staff members based on trust and accountability, or when improving systems and processes, and this is a priority for that work setup. When this will not going to work well is when a concrete decision needs to be made quickly. Gathering feedback and testing the waters with team members isn't necessarily helpful or feasible. The laissez-faire nurse is the opposite of the autocratic nurse. Laissez-faire comes from French and it means let it go, let it be. In this style, the nurse provides no specific direction for team members and adopts more of a hands-off approach to managing. When this style works best is whenever the nurse's team is already experienced and self-directed and doesn't necessarily need a general giving orders. This style will, however, will not work well when specific decisions need to be made and implemented or when the team members are inexperienced and new. There's another style, and this will be the multicratic or participative type of leadership. This is a combination of autocratic and democratic. They will allow for staff input, but the final decision will be made by the managers. The transformational style of leadership is sometimes also called visionary. In this style, the nurse manager is focused on the big picture, how to improve patient care, better systems and processes, and what's the process to get there. When this style works best is when the workplace, in this case, a hospital or clinic or other healthcare facility, is in a big need for changes and improvements. This style, however, will not work well when day-to-day decisions making are required on small or very specific issues. The servant type. The servant nurse leader focuses on team success via individual team members. And despite the meek-sounding name, this management style has been gaining popularity over the past few years. The leader will target team members' needs and will ensure that they have the skills, relationship, and tools to achieve individual and group goals. This style works best when a team has diverse members and different tasks and responsibilities. It will not work, however, when top-down decisions need to be made or a group needs to follow collective directions. So, this being said so far, which type of nurse leader are you? Think about it and think about what kind of leadership style works best for your job or your career goals. LVNs have always managed the care of the patients they cared for. When looking for ways to cut costs in healthcare, many formerly RN positions were nowadays replaced by LVNs. Nursing homes are staffed primarily now with LVNs. Only nursing homes with 100 beds or more are required to have an RN 24 hours a day, so that is why so many are licensed for only, keep in mind, 99 beds. The NCLEX exam has gradually increased the percentage of questions in the management and supervision category in order to ensure that student nurses are educated and have at least a minimum competency in this area as well. The primary functions of an LVN in any type of leadership role are delegation, supervision, responsibility, and accountability. When delegating, it is very important to transfer responsibility for a task to a competent individual given the situation. However, the nurse retains the accountability for the delegations. There are 5 rights of delegation: the right task, right circumstances, right person, right direction or communication, and right supervision or evaluation. I'll give an example. Having an aide ambulate a patient having chest pains would not be a good delegation, right? Nor would be assigning a new CNA the most difficult patient in the unit. So here are some tips for successful delegating. Know what your team members are able to do, including their scope of practice and their educational preparation. Plan ahead. Always plan ahead in order to avoid problems. Decide what tasks to delegate. Make sure to match the task to be accomplished with the abilities of the individual to whom you are assessing it. Communicate clearly the task you're delegating and your expected outcomes. Provide the necessary authority and responsibility to accomplish the task to the individual to whom you are delegating. Monitor and assess the performance of the task. Always provide positive feedback. Provide feedback as it appropriate. Take corrective actions when necessary. Now, supervision involves making the appropriate judgments about clinical assignments and delegation of tasks, and then following up to see that tasks were effectively accomplished. Supervision begins when the LVN implements the plan. The implementation step includes giving instructions about what needs to be done and when. The nurse must include any specific issues, such as telling the aide that a client must complete morning care before going to physical therapy at 10 a.m. In addition, the nurse needs to tell the aide about any potential problems, such as a client who may experience dizziness when getting up, secondary to any type of antihypertensive medication. Supervision also is necessary throughout the implementation step. The LVN must check with the aide during the shift to assess whether tasks are complete, what the outcome is, whether something has changed that may interfere with the work, or whether the aide is having problems accomplishing the task safely. This evaluation step of delegation will also include supervision of the aide in that the LVN will ensure that the client received the appropriate care, that the client's needs were met, and that problems were addressed. Providing feedback to the aide also is important in terms of letting them know that they did a good job, or asking questions about the client's response to the care provided. Now, responsibility is a duty or assignment related to a specific job. It means being obligated to perform certain activities and duties. As compared to that, accountability means being answerable for the consequences of one's actions or inactions. LVN may be sometimes hesitant regarding delegation and supervision of unlicensed personnel due to this not being emphasized enough in their nursing education. There are some factors that may interfere with effective delegation and supervision, and I will mention a few of those. Reluctance to delegate from fear of overloading a coworker or the desire to do everything alone. Inability to move out of the role of direct caregiver. And it will be many times that you will hear an LVN saying, "It is easier to do it myself." Miscommunication regarding specific directions and desired outcomes. Desire to be liked by coworkers, which sometimes interferes with the ability to delegate, supervise, or sometimes both. The solution is more education regarding leading and managing for the LVNs. Although LVNs as team leaders have the primary responsibility of delegating tasks to aides, other functions are important for the LVN leader or manager. These functions will include collaboration, advocacy, resource management, and time management. We'll look into some of those. Advocacy, that means promoting the cause of other person or organization. Nurses in general act on behalf of their clients. The Code of Ethics for Nurses, as published by the American Nurses Association in 2015, will state, and I quote, "The nurse promotes, advocates for, and protects the rights, health, and safety of the patient." LVNs function as client advocates by understanding the rights of all clients, remaining informed about diagnosis, treatments, prognosis, and choices, contributing to the provision of information and education, supporting the client's decision, and communicating with other professionals. Collaboration involves a team effort to achieve client care outcomes. LVNs maintain open and effective communication with all team members. They also assist in solving problems related to client care. LVNs may contribute to decisions about client care and unit activities by participating in client care conferences and unit meetings. Lastly, collaborative behavior for the LVN involves participating in the management of the unit by following all the appropriate channels of communication and supporting the group in this collaborative effort. Resource management, the responsibility of all who work in healthcare, means using resources which include not only actual money but also supplies and equipment and buildings and personnel in an optimal way. Nurses who provide are responsible for controlling the use of resources and recognizing when resources are inadequate. In addition, they must know the costs of resources and the importance of using cost-effective measures when caring for clients. Time management. Time is an essential resource, and particularly in today's fast-paced healthcare environment, time management will involve organizing time as well as delegating tasks to other personnel and essentially optimizing the available time. There are three basic steps for managing time. During the first step, the nurse makes time to plan and establishes priorities. The second step will involve completing the highest priority tasks and moving from completing one task to beginning another. The final step requires that the nurse reassesses and reprioritizes tasks based on any chances. Healthcare organizations are the setting in which most nurse leaders work. Formal nurse leaders play an important role in the operation of healthcare organization. Clinical nurse leaders usually emerge at the front lines of the organization, the places where the patient care is actually delivered. So nursing is a practice discipline and is geared toward the delivery of healthcare, while the coordination of safe and effective patient care falls on the shoulders of the leaders. As mentioned previously, there are multiple levels of leadership. Thus, some leaders are a little bit further removed from direct patient care than others. Nonetheless, the efforts of nursing leaders ultimately link to the coordination of patient care. Care coordination refers to the process of connecting healthcare services and resources to patients and is one of the distinctive contributions that clinical nurse leaders make in the patient care. Because communication is an attribute of effective leaders, as we described them previously, it is actually a key interrelated concept. Clear communication is central to effective leadership. Leaders who communicate unambiguous and consistent messages in a timely manner help followers understand the organization's directions, decision-making processes, and changes that may be underway. Listening is an essential aspect of communication. Only by listening to peers, followers, patients, and others will the leader understand all dimensions of a problem or opportunity. Effective leaders also provide mechanisms to foster clear communication throughout the organization. Effective collaboration within and among organizations and within and across disciplines is essential to efficient organization. Skilled nurse leaders encourage and role model this behavior. Collaboration enhances communication and delivery of care. Nurse leaders help ensure that the actions of the organization or the unit and individuals will contribute to healthcare quality. Both formal and clinical nurse leaders are attuned to the standards and processes that an organization uses to provide high quality of care. They are involved in improvement initiatives and any other change processes to meet the quality goals an organization will set for itself. Often, nurse leaders collaborate with others through professional organizations and regulatory bodies to establish the quality standards for nursing and healthcare. Use of evidence is important for effective leadership. Formal leaders use evidence about different leadership and management approaches to create organizational processes and work environments that contribute to satisfaction, productivity, and retention of nursing staff. Clinical leaders use research-based evidence and best practices to ensure healthcare quality and often will guide other nurses in evidence-based practice. Now, how does ethics links to all this? Well, ethics is also important for effective leadership. Ethical integrity is a core element of all types of leadership. Formal leaders practice and role model high ethical standards. Clinical and interprofessional leaders rely on their knowledge of ethical principles and decision-making models in order to protect and advocate for patients in all aspects of patient care.